Axios Local is bringing smart brevity to a city near you. Local will deliver scoops, offer sharp insights, and curate the best local reporting. Our events, called Smart Take, will help readers better understand the most consequential news unfolding in their own backyards. With Local, we focus on what matters in your community.
Welcome to our Health Equities and Community virtual event. I'm Russell Contreras, the Race and Justice reporter here at Axios, and I'm coming at you from Rio Rancho, New Mexico. Welcome to our audiences on Facebook, YouTube, Twitter, LinkedIn, and on Axios.com. Join the conversation today on Twitter with @Axios and hashtag Axios Events. Over the next 30 minutes, I will be joined with my colleague, Axios Atlanta reporter Crystal Dixon. We will examine how social determinants impact health outcomes, both in Atlanta and across the nation. Our first guest is the president and CEO of the Morehouse School of Medicine, Dr. Valerie Montgomery Rice, joining us from Atlanta, Georgia. Dr. Montgomery Rice, thank you for joining us. How are you doing today?
I'm doing well. Thank you for having me, Russ.
Before we get into some of the challenges of equity in healthcare today, take me back to how we got here. We've had a century of Medicare, Medicaid. We've had about a decade of the Affordable Care Act. Most people think that we should have tackled equity in healthcare since then. What challenges do we face now, despite those monumental changes?
How we got here, Russ, is that we never have dealt with the real issue that underlines these health inequities. We've never dealt with the social determinants that influences people's access to care. We never dealt with the policies that undergird why people are, their outcomes are determined by their geography or their zip code. We've never dealt with the social issues around racism and racial injustices that have led to health inequities. And what we saw with this COVID-19 pandemic was that we couldn't get around it, that this COVID-19 pandemic did not pay respect to people's person and place, but it shined a light on the fact that if people were in situations where they couldn't socially distance, if people were in occupations that allowed them to have increased exposure to this virus, they ended up with the disease. And then we saw that because of the chronic diseases of diabetes and hypertension and heart disease that are vascular in nature, and this virus infected the vasculature, that those persons who were more susceptible were those people who had those diseases. And unfortunately, those were the chronic illnesses that lead to health disparities, particularly in African Americans.
50 years ago, when Robert Kennedy visited the Mississippi Delta and the Lakota Nation, the problem then was hunger and how access to food. Today, we have access to food, but not the correct access to food. It seems the problem now is malnutrition and obesity. Why is that still a concern today?
Well, again, you got to deal with these social determinants of health. So I am taken back to a project in our Prevention Research Center here that's funded by the CDC. And they started a project several years ago where they started partnerships with the corner stores. It was called the Corner Store Project. And they went there and they asked the corner store owners, why don't you have fresh fruits and vegetables for your patrons? And they said, well, because they don't buy them. They stay on the shelf too long. The food spoils, etc. And so what we found was, again, those social determinants that would influence people's ability to access, not that the owner of the store didn't want to provide it, didn't have a supply chain mechanism, right, that allowed them to keep the replenishment of the fruits and vegetables. So what we did at Morehouse School of Medicine, we first asked the community, if you had access to fruits and vegetables, would you utilize them in your practices of how you prepare your meals? And they said yes. But when we go to the store, the food is spoiled and we don't have a Publix or a Kroger or a big chain near us that we can get a fresh supply. So we then, first of all, determined the need, understood that once we determined the need, would the resource be utilized by the community? We asked the community what they needed. And then we did the most critical part. We trained the corner store to be able to partner with a Publix or a Kroger or a big chain food supplier such they could get a ready supply of fruits and vegetables, and that they would get the right amount such that it wasn't sitting there on the shelf spoiling. And so it is a matter of creating the opportunities through access and partnership with the community. And therefore, you can then address issues of poverty and obesity, which then, when I write a prescription for a person, and I'm writing a prescription for them to manage their diabetes, it doesn't just include a drug. It may include incorporating fruits and vegetables in your diet, and they have access and empower them to make the change in their health that decreases their chances of diabetes or the consequences of diabetes.
And how important is the cultural competency of people who work in this industry? I can understand someone who may be dealing with an ailment, diabetes, obesity, but I don't want to be judged. I don't want to go in there and deal with a healthcare provider who's going to immediately judge me and my diet. How important it is to have people that look like you providing healthcare, to have really serious, honest conversations and need to be receptive of that.
So, Russ, we have spent a lot of time at Morehouse School of Medicine speaking about educating the healthcare professionals that the world needs. And what we do and how we do that is so informed by the community. And we do know that the data really does show that when you have congruency in the some attribute of the patient and the providers, when there's concordance, you will see an improvement in outcomes based on increased compliance by the patient, and also an increase in the understanding of the recommendations to make to that patient by the provider. So we believe wholeheartedly in this. But we also know that that's not always possible. So we develop our curriculums when we're educating and training our healthcare professionals, that we ensure that they are out in the community, regardless of their race and ethnicity. They must be out there in the communities that they are going to serve to understand those communities. And one example of that is at Morehouse School of Medicine, we have a longitudinal year-long community health course that all of our medical students do at the beginning of their first year. Under the guidance of their preceptors, they work in groups of 6. They go to the neighborhood planning units, and they are working with the community and asking, what is a problem that you are trying to solve related to your health? They co-develop the solutions. They co-implement the solutions with the community. Therefore, the community learns from them, but more importantly, our students are learning from the community early on in their career, so that they are becoming not just culturally competent, but culturally responsive, because they are understanding the needs from the eyes of the community and not just from a textbook. So how we educate and train the next generation really does impact cultural competency and cultural responsiveness.
In our final moments we have together, right now, there is a movement to push back against the idea that we have systemic racism in this country, that there's perpetual inequality. Many folks will say that's just the act of a few individuals. Why is that belief a matter of life and death? If we're not going to address these systemic problems and equity in healthcare, why is that a matter of life and death?
Well, one of the things that we had to absolve people early on in the COVID-19 pandemic was that Black people were catching the virus and dying from the virus at a higher rate because they were Black. No, Black people, Indigenous people, brown people were the ones who were the frontline workers. They were the ones who could not go home and socially distance and still do their job, okay, and get paid. They were the ones who were continuing to deliver our packages, pick up our trash, make sure that our utilities stayed online. And so what we recognized is that we had a systemic problem of injustices in this country that have led to those persons being on the front line. And many of us know that that is undergirded by policies and practices that have not allowed people to move beyond the circumstances of their birth. And so much of it is conscious and unconscious biases and the lack of opportunities for people to have access to educational opportunities. If you look at a public health graph and you look on the x-axis of socioeconomic status and the y-axis of health, and you draw a slope of a line, what you find is that if you increase people's educational opportunities, that they graduate from high school, they get a trade, so they graduate from college, or they go get another degree, et cetera, they move along that slope. And every time they move along that slope, it is because they increase their socioeconomic status and they're able to make differently informed decisions that do influence their health. And so we know there is a clear linkage to educational opportunities and educational outcomes and health outcomes. And so if we want to do something in this country, if we can only do one thing, we would ensure that there's full pre-K for everyone and that students and children have the opportunity to advance along our educational system without resistance, so that they can be empowered to make decisions that influence not just their socioeconomic status, but also will influence their health.
Dr. Valerie Montgomery Rice, thank you for joining us. This was a very powerful discussion.
Thank you for having me, Russ.
And next, we have a view from the top with Mia Boykins.
Thank you, CVS Health, for sponsoring this event today. Now, joining us from Michigan, the Vice President and Chief Health Equity Officer at CVS Health, Dr. Jonay Caldew.
Hey, thanks for having me. So excited to be here.
Thank you so much for joining us. I'm honored to be speaking with someone who is so revered in the medical community. You have a number of accolades, including being CVS Health's first Health Equity Officer. Would you please share more about your role and also highlight some of the priorities that you're focusing on?
Absolutely. It's certainly such an honor to be the inaugural Chief Health Equity Officer of a Fortune 5 company. I mean, we've been a leader in health equity for many years, actually. Within Aetna, we were the first healthcare plan to actually collect race and ethnicity data to understand disparities. We certainly at CVS Health have really stepped up throughout the pandemic to advance vaccinations and testing in underserved communities. So it certainly is an honor to be in this role at this time. So some of our priorities, really, it's around aligning all of our various assets around health equity and making sure every single CVS Health colleague has the tools they need to advance health equity in their everyday jobs. We're also really focused on data and data infrastructure. We all know that if you can't understand and measure disparities, you're not going to identify them and be able to address them. So we're really focusing on our data infrastructure. And then finally, bold actions, and that's what we'll talk about more today. Bold actions, getting into communities, understanding what communities need, and leveraging all of our CVS Health assets to be able to really decrease health disparities and advance health equity. And that's what I'm really excited about, leading with a great team here at CVS Health.
Definitely, you were integral in the COVID-19 response. So 2 years in, why is it so important for us to address health equity?
Well, I think it's, first of all, really important that we just level set on what we even mean by health equity. And quite simply, the definition of health equity is that everyone has a fair and just opportunity to be as healthy as possible. And what do we mean by that? That means regardless of the color of your skin, your disability status, where you live, your religion, your primary language, everyone should have an opportunity to be as healthy as possible. It also recognizes social determinants of health. So things like access to affordable and high quality housing, education, transportation, jobs, all those things that quite frankly have more to do with someone's health outcomes than what happens inside the walls of a doctor's office or a hospital. And it also recognizes that, unfortunately, even if you just completely eliminate poverty, you would still have disparities and differences in health outcomes across races, particularly. And that's because of, unfortunately, all of the ways that we divide resources and opportunities in this country. That includes racism, but also sexism, classism, ableism, all the ways we treat each other, unfortunately, that cause disparities. And so we saw that play out in COVID-19, and that's why it's so important that we all really step up and collectively advance health equity.
CVS Health has recently announced the rollout of its Health Zones initiatives. Could you please explain what health zones are and let us know what equity issues the zone will address in Atlanta?
Absolutely. We're so excited to have rolled out our Health Zones initiative. And it's really about advancing health equity and particularly addressing those social determinants of health that I talked about earlier. So in Atlanta, we're focusing on the 30318 zip code. We know that in that zip code, it has a primarily African-American population and also an older population. We also know that in that particular zip code, there's a lower life expectancy compared to the national average and to the surrounding zip codes. So we really worked with that community and said, okay, how can CVS Health leverage our assets? How can we partner with the local food bank? How can we address things like aging and mental health and Alzheimer's disease? So we really are bringing all of our assets to bear, working very closely with the community, and then tracking outcomes over time, and particularly how we're addressing social determinants of health. I'd also say one thing that's really important and something we're proud of is our housing investments. In 2021 alone, we invested $185 million in affordable housing in underserved communities across the country. And that's really, really important as we think about those non-clinical social determinants of health and how we can advance people being able to have the opportunity to be as healthy as possible.
I'm looking forward to the updates on this initiative. So, in your eyes, what would be an equitable healthcare system and how do we get there?
There's no question that we don't currently have an equitable healthcare system. First and foremost, everyone does not have health insurance, so everyone does not have access to a primary care provider. And that's something that we are advancing access to primary care here at CVS Health. We need to make sure that we have provider diversity, making sure that our care teams look like the communities that we are serving. We have to make sure that as a healthcare system, we are really identifying and addressing disparities, something I talked about as far as one of our key priorities to advance health equity here at CVS Health. And of course, we have to address those social determinants of health. When you're touching the healthcare system, you should be screened to see what resources you may need, and then having those seamless connections to make sure you get access to housing, jobs, food, transportation, all of those things that are really, really important. And if we do those things collectively and do them well, we will get closer to having an equitable healthcare system.
Thank you for joining Axios, Dr. Jonay Caldew.
Thank you.
I'm Crystal Dixon, an Axios Atlanta reporter. Our final guest is President and CEO of the Black Women's Health Imperative, Linda Goler Blount, who is joining us from Atlanta. Linda, thank you so much for joining me.
Thank you, Crystal.
Okay, so Black Americans are far more likely than whites to face hurdles when it comes to healthcare access and health outcomes. How do you see this playing out in Atlanta, and what is your organization doing about this?
You're right. Black Americans, as we have seen, particularly in stark relief in these last 2 years with the COVID pandemic, have had less access to testing, to preventive services, to quality treatment. We've known this for decades, actually. And we've seen it in Georgia and Atlanta. When we think about the COVID-19 pandemic, initially where testing sites were located, they tended to be in the suburbs, so you needed a car to get there. And if you didn't have a car, it made it more challenging. We also know that in hospitals, when Black Americans presented with typical COVID-19 symptoms, cough, fever, they were less likely to be tested, less likely to be diagnosed with COVID. And that contributed to seeing higher death rates from COVID-19. But this isn't just limited to COVID-19. We see this in diabetes and heart disease, in breast cancer and cervical cancer. Black Americans and low-income Americans typically have less access because they tend to be uninsured or underinsured. Atlanta happens to be in a state that has not expanded Medicaid. So if you're low income, you're less likely to have access to health insurance. And you're also less likely to receive quality treatment. Still, as hard as it is to believe, 30 to 40% of physicians believe that Black Americans and Black people don't feel pain as much as white people. So if a Black person presents in the emergency department with, say, sickle cell crisis, they are likely to be treated as though they're drug seeking and not actually having a medical emergency.
So COVID-19 highlighted some of these disparities. Do you think the pandemic widened the gap when it comes to progress on health equity, or do you think the broader awareness has helped turn into measurable action on this topic?
I hope that the increased awareness will result in increased activity and behavior and focus on these health disparities that we've been talking about for years. I mean, clearly, COVID-19 shone a very bright light on the disparities in the healthcare system that some of us have been talking about for a long time. I can remember in 2020, a number of people saying to me, "Oh, I had no idea health disparities was still a thing," or even after the murder of George Floyd, I had no idea racism was still a thing. I had no idea these two things were related. So we still have a long way to go, but I'm hoping that now that we've seen the stark disparities, that policymakers, healthcare leaders, public health professionals like myself will understand the historical significance. I mean, this all didn't just happen in the last few years, and actually take steps to change the behavior, the policies, and the practices that would need to be changed to eliminate these health disparities. Because it's important to note that these disparities that exist are not biologic or genetic in the making. These disparities come about from what we refer to as the social determinants of health. And because people don't have access to a number of factors like education, living wage, good housing, obviously healthcare, they simply can't make the choice to be as healthy as possible.
So let's talk about Black women more specifically. The maternal mortality rate for Black women in the US, which is the richest country in the world, is staggering. What do you think is at the heart of these inequities?
That is really just a terrible statistic that the United States is 49th out of 50 developing countries when it comes to maternal mortality, and it has not improved. In fact, it's gotten worse. What we know from Black maternal mortality, we've seen many news reports of Black women not feeling well, telling their providers, "I don't feel well," and being ignored. So fundamentally, the providers, nurses, physicians, those in hospital were not listening to, not believing Black women when they complained about feeling unwell during and around labor and delivery and postpartum. Part of that is we go back to these social determinants. Part of that is how Black women are perceived still in society as not being valuable. Many people still believe that Black women shouldn't even have children. And so our concerns about our health care are not taken seriously. It's a challenge, but honestly, there's a policy solution. Hospitals, providers all have to meet certain quality standards. Imagine if there were a quality standard around Black maternal health outcomes and infant health outcomes that was tied to reimbursement. If providers thought, for example, they would not be reimbursed if they didn't meet certain quality metrics around Black maternal mortality, I guarantee you we would see the Black maternal mortality rate drop. There's no reason for Black women to die 3 to 4 times more often, but we see it because Black women tend to give birth in hospitals that have lower resources, don't have the kind of emergency preparedness when emergencies arise. And so they simply don't have the resources in hospital that they need, but also depending on where they live, they may have to travel an hour to 2 hours just to get the prenatal care because we've seen these lower resource hospitals close.
Okay. You touched on this earlier, and I wanted to give you an opportunity to expand upon it. We've seen rich and famous Black women like Serena Williams and Beyonce talk about have been having to be vocal about, facing these potentially, fatal pregnancy complications. You also mentioned that Black women are less likely to be believed by doctors and their white counterparts. Why do you think, we're in this situation today? And, how do Black women combat this so-called medical gaslighting, as some have called it?
Yeah, that's a really unfortunate but appropriate term. Black maternal mortality and maternal health is one of the few conditions that actually has nothing to do with poverty. We talk about what happens in low resource areas, but Black, highly educated, professional, high income earning women have worse maternal health outcomes than white women without an 8th grade education. And it simply comes back to whether or not they're believed, whether or not they're valued by their healthcare providers and taken seriously. But we also know there's something called the epigenetic expression of stress, that literally stress is in our bodies, it's in our DNA. It's 400 years in the making. And we know that for Black women in stressful jobs, as I said, high income earning, executive level roles, they tend to have high levels of cortisol. Black women have about 15% more cortisol, which is a stress hormone, in their bloodstreams than white women. And cortisol can trigger your inflammatory response, raising your risk for diabetes and heart disease, but it also can change your metabolic response. And we know now that this elevated level of cortisol and chronic exposure to stress is responsible for much of the obesity that we experience and the adverse health outcomes, but this also impacts maternal health as well and infant health. So we really do need to look at this issue from a systemic perspective and make the policy and practice changes that need to take place to prevent this.
We've talked about race and economic status. What are some other social factors that we have to, discuss that we don't give much attention to that can have an impact on a person's health?
Race is a social construct. And so it's important to know that there's nothing about being a Black woman that should cause you, or a Black man, that should cause you to die more often from certain diseases. It is the experience of being Black in this country. So we talk about these social determinants of health, chronic persistent poverty. There was just a study that was produced that looked at New York City. And if we were actually in New York City to achieve racial equity, and this is true in Atlanta as well. In New York City, 78% of Black people would have to move. In Atlanta, some 68% of Black people would have to move just to get to racial equity at the neighborhood level. We know that racial segregation is responsible for health disparities. If we could tomorrow eliminate racial segregation, we would eliminate health disparities and we'd eliminate income inequalities. And it's interesting, in social sciences recently have been talking about something called social herd immunity, which means that if Black people had pay equity, Black women we know earn 62% of the salary that their white male counterparts earn. If we had no segregation, well-funded public schools, health insurance, those kinds of social factors actually would confer an immunity to the Black population and brown population to make them more resistant to the kinds of disparities that we talk about. So the Black Women's Health Imperative, we're talking about, how do we do this? How do we change policies? How do we change the practice of care? How do we change the workplace where Black women are to reduce these stressors, promote equity in pay, and obviously in education and access to healthcare, so that Black women can literally have this sort of social immunity, this herd immunity that would occur if we actually had equity across the social determinants of health.
Linda, I want to thank you so much for joining us for our conversation. Thank you so much for joining us today.
Thank you, Crystal.
Thank you all for joining us this afternoon for another virtual conversation that has made everyone smarter, faster. For more information or to sign up for the Axios Atlanta newsletter, visit axios.com/local or download the Axios app. Thank you all for joining, and we'll see you on axios.com.